Hi, everyone. Just wanted to say thanks for coming. I know I'm competing with the annual faculty meeting and also some nicer spring weather. So thanks for coming. Just wanted to quickly introduce myself. I'm Soumya Rangarajan. I'm a clinical assistant professor in geriatrics. Just briefly about me, I'm originally from Cleveland, Ohio, went to college here at U of M, so I bleed maize and blue, did my medical training at the University of Illinois, my residency in internal medicine and fellowship in geriatrics at the Medical College of Wisconsin in Milwaukee, and then ended up back as an attending. And I primarily practice as a hospitalist and also doing some work on the hospital care at home, and that'll be the topic of our talk today. I don't have any disclosures in regards to this presentation. So everyone is pretty well aware that we get these emails all the time about the university hospital being extremely high occupancy. So I remember some from September, some from December, and we've been getting a few this month in April. This has been kind of an ongoing issue, even really before COVID, but it really became a lot more prominent with COVID. It's definitely an opportunity to try to change the way that we provide care for hospitalized patients. So who is actually getting hospitalized? So this is some data from the Agency for Healthcare Research and Quality from 2018, so prior to COVID, but I think a lot of the numbers are still relevant today for our non-COVID patients. So far and away, the number one diagnosis for hospitalized patients is sepsis, but high up there is heart failure, interestingly osteoarthritis, which really are patients who need joint replacements and usually in the ortho realm, and then other things we deal with frequently on the medicine side, pneumonias, diabetes complications, COPD, you can see cellulitis, urinary tract infections, which are tried and true medicine admissions that really make up a significant proportion. Some of these 2% in heart failure, 4% of total admissions to the hospital. And the question is, what type of patients are we seeing? And we can see for some diagnoses, really the patients trend more older. In heart failure especially, 73.5% of the patients that we take care of are Medicare patients on average. For urinary tract infections, about 68% are Medicare patients. And while not all Medicare patients are elderly, the vast majority are. The next slide kind of puts this even into more relief that you can see that in all adult admissions that were non-OB hospital admissions, of them, about 16% of all of those admissions are women over age 75, about 12% are men over age 75, and then almost 11% of each are men and women between 65 and 74. So really the vast majority of the patients we're taking care of in the hospital do trend older. And we found that about 50% of all adult non-OB hospital admissions are for geriatric age patients. And then when you look at the type of conditions a lot of these elderly patients are coming in with, again, you see sepsis, heart failure, pneumonias, and in women over 75, urinary tract infections are a very common source. Hospitalization for the elderly is not without its risks. We have a lot of data that shows that hospital-acquired impairments such as sleep impairments, hearing impairments, vision impairments get worse in the hospital, and this can lead to delirium. They actually have found in some of the literature that 20% of patients who are elderly who are hospitalized do develop delirium in the hospital, significantly increased risk of falls, increased risk of pressure ulcers, UIs, urinary incontinence, the use of restraints is often the case, especially in patients with underlying dementia. There's an increased risk of hospital-acquired infections. They found about 5% of patients who are hospitalized who are older do develop hospital-acquired infections. And then, of course, there is a significant risk of functional decline for older adults who are hospitalized. So definitely it's not without its risks. And then also the cost of hospitalization is very high. They found that 1/3 of total expenditures in healthcare in the United States are from hospital care. So this is a really interesting study out of the University of Iowa. So they actually had a study where they put wearable sensors on various healthcare staff and then tried to find out how much of the time are they actually spending with patients. So this is really interesting data because it shows for physicians, and I can definitely attest to this when I work on the hospitalist side, that a lot of their time is actually spent in the physician's workroom, about 40% of the time, and only maybe about 12 to 13% of the time is actually spent in the patient room. So versus the vast majority of the time that patients are spending is with nursing staff. The nurses are really either in the patient room or directly outside their patient room, and about 86% of the time patients are spending with nurses, and only about 13% with their physicians. So, and this is not, to say that there's anything wrong with the way that, physicians are doing things. That's just, the nature of the type of work we do. A lot of it, is documentation, looking at labs, looking at images, so, and not necessarily being in with the patients. So, they found that in a 12-hour shifts, I should say this in an intensive care unit, not on the general floor, but I think some of this is also attributable to the general floors as well. So, so in a 12-hour shift, physician visits to patient rooms lasted only about 72 seconds with a median duration of 30 seconds. And really only 0.2% of these patient visits lasted more than 15 minutes, typically if you're having goals of care discussions with the patients or their families. So given the data that I just showed you, just using the quote from Thomas Edison, there's a way to do it better, so let's find it. So that gets us to hospital at home, which is not a new idea. Actually, looking at some of the literature around hospital at home, the first ever mention it is in the British Medical Journal in 1894, which was around the time that Sir Arthur Conan Doyle was publishing Sherlock Holmes in the Strand magazine, that it pointed out that some people really don't like coming to the hospital. They don't like the noise of the hospital, and they just kind of want to be in their own home. So, so it's actually a centuries old idea. And actually, a lot of early care in medicine was never really in the hospital. There was some interesting literature that in early Arizona, hospitals didn't actually exist. In Tempe, Arizona, doctors made house calls. This was a doctor riding on horseback to a patient's house to be able to make some house calls. And they didn't even set up their first hospital in Tempe, Arizona until March of 1944. So really, hospitals are really a phenomenon mostly of the last 75 years or so. So why did we switch to hospital care as the standard of care recently in this last century or so? So hospitals are a standard venue for treatment of serious and sometimes not so serious illnesses. Some are good reasons and some are, maybe not so great. So some of the good reasons is because there's been a great expansion in biomedical knowledge and technology and subspecialists, improved patient access and convenience in the hospital. It is easier for patients to access the hospital. It's also increased efficiency for physicians. And again, hospital medicine is a relatively new specialty. It's really been in the last 50 years or so that it's really grown. And again, because it allows that efficiency that primary care physicians don't have to round in the hospital on their own patients, you do have the increased efficiency of doctors who only provide care for hospitalized patients. But some of the reasons that, are not things that we generally think are beneficial, or that health insurance companies have had a lot more of a role in the last 50 years, third-party payers. And so their influence has also caused care to really move into the hospital, and then also increased litigation and liability concerns. So because of increased risk of lawsuits, they find that there is more need for imaging, more need for testing, and that tends to gravitate patients to the hospital. So hospital at home actually has really started mostly abroad, and really mostly in Europe. So it first emerged clinically in France in 1978. And then also New Zealand had something called the extramural hospital that they started around the same time in the late 70s to early 80s. So the first real major study of a hospital at home program was an observational study done in Peterborough, England, which is near Cambridge. They collected data from 1978 to 1983. The study was actually published in 1991. So they were actually given a pretty large grant at the time by a foundation, £204,000, which currently would be equivalent to about 1.2 million pounds in current currency, or $1.6 million. And so with this very generous donation, they were able to really do an observational study of patients who really wanted to be cared for at home rather than in the hospital. And they found that there was greater patient satisfaction and lower costs of care. The only downside was there was some selection bias related to this. About 1/3 of the admitted patients had terminal cancer and really didn't want to be in the hospital. So they were kind of self-selecting the type of patients who really wanted to be at home. And it also included some stroke patients, some cardiac patients, and some with respiratory illness. And I would also preface this by saying that this was really a nursing-based program where the nurses were working with the patient's general practitioner. So it's really, this particular program was more similar to what we would consider home health rather than an actual hospital care at home program. So from the 1970s to the 2010s, there was an explosion of hospital at home programs across Western Europe, and so UK, France, Germany, Italy, the Netherlands, and Spain, also included Israel, and then Canada, New Zealand, and Australia. And there are multiple RCTs that they studied in both generally and also in specific populations, including CHF patients, COPD patients, stroke patients, and interestingly, even those with neuromuscular disease like ALS who presented with respiratory failure. And they found in all of these RCTs that there were very encouraging outcomes, both for patient satisfaction and quality of care provided. So I'm going to focus on one of these programs in Victoria, Australia. So it's a state in Australia of about 6.6 million people. It's about the same population as the state of Indiana. And in Victoria, every metropolitan and regional hospital has a hospital care at home program. And 6% of all their hospital bed days in the state of Victoria are provided through hospital care at home. So 58% of their patients with DVTs are in the care at home program, 25% of patients with cellulitis. And actually, it's a pretty enormous number of bed days that they've provided through the program. So 32,462 episodes in 08-09, which is actually equivalent to a 500-bed hospital, so which is quite large. So what do all these countries have in common that the United States does not? They have universal healthcare systems. So, I'll go into that a little bit, but definitely there is an incentive financially in these countries with universal single-payer health systems to provide this level of care at home. So. So I'm going to delve a little bit into Australian health policy. So Medicare in Australia is a single payer universal healthcare system funded by taxes. The healthcare is capped at 9.5% of their GDP, which is very different than in the US, where it's hit almost 20% of the US GDP. So they can't build a new hospital like we're building the Pavilion at Michigan Medicine, because the state has to essentially approve all new hospital beds. So there's been no net growth in public hospital beds. They found that even though there was indirect incentives like new technology that allowed people to go home and do portable ultrasounds, portable x-rays at home, they didn't really find much growth in Australia until 1994. At that time, the state government of Victoria reimbursed hospital at home at exactly the same rate as an inpatient hospital stay with no caps. And so suddenly, when doing hospital care at home is getting paid exactly the same as doing care in the hospital, there was an explosion of interest in hospital care at home in Australia. Also, the Australian government is currently funding expansion in hospital beds, but they preferentially fund the equipment and devices needed to do more hospital care at home. So I found an example of what a typical handoff would look like, just like the handoffs that our hospitalists would do with each other from the day team to the night team in one of the hospitals in Australia, the Royal Melbourne Hospital in Victoria. And as you can see from this list, there are some pretty sick patients on this list. Enterococcal sepsis, infected septic joint, a pre-BMT AML patient. So they're taking care of some pretty sick patients, a nocardia infection. And all of these things can be provided at home in the Australian program. So, so all these IV antibiotics, you can, for anticoagulation, you can do Lovenox at home. They're doing Dapto at home, which obviously requires pretty significant pharmacy involvement. So this handoff really looks similar to what we'd see on a medicine faculty hospitalist service or one of the resident services, but they're actually doing this entirely from home in some of the programs in Australia. So getting to the US, so due to some of the financial and government incentives we talked about earlier, this has been a relatively late process in the US. So the first program in the US that was studied was actually in the late 1990s. And actually Dr. Julie Bynum, who's now our Vice President of Faculty Affairs and one of our physicians in geriatrics and palliative medicine, was actually a medical student at Johns Hopkins at the time and was involved in this study. So they conducted a feasibility study in 1995 at Hopkins, and they identified 4 conditions that were most amenable to care at home. So these were community-acquired pneumonia, exacerbation of congestive heart failure, exacerbation of COPD. So it's called COAD because at that time it was basically chronic obstructive airway disease instead of pulmonary disease, but essentially it's the COPD and cellulitis. And these are some of the comorbidities of the patients that they found that were eligible for hospital care at home. So many of them had hypertension, COPD, CHF, diabetes, coronary artery disease, and even some more serious illnesses like myocardial infarction and CVAs or strokes. So the Johns Hopkins initial pilot study was conducted between 1996 and 1998 at their Bayview Medical Center. And all the patients were 65 and older, all were under Medicare, and they had these 4 diagnoses that were previously identified. So COPD, CHF, cellulitis, and pneumonia. And 478 patients presented with these diagnoses. About 104, a little less than 1/3, did not meet geographic or insurance eligibility. About half of them were not medically eligible. So of the remaining 145, only 17 were enrolled. So it was a very low sample size. So definitely it was not a high-powered study. But with that said, they did find high patient satisfaction, and costs were about 60% of what they would be in the acute hospital. So one thing I will note about Maryland that is interesting, and you may not all know, is that it operates the nation's only all-payer hospital rate regulation system. So that essentially means that all payers pay the same set rate for the same diagnoses. So if somebody comes in with CHF who's a Medicare patient or a Medicaid patient, they're paying exactly the same as somebody with commercial insurance. So, so what that means is that there is no difference between hospitals based on payer mix, which is usually a case in most of the other states in the country. So essentially, it doesn't matter what kind of insurance they have, they're getting paid the same amount. So again, because Maryland has some unique policy issues, and also this was only at Johns Hopkins Hospital, they really wanted a larger trial with more patients and also representing a larger swath of the country. So, so there was a larger multi-center study that was done about hospital level care at home. They basically divided the groups into an observation group of usual care in the hospital from 1990 to 2001. They were recruiting patients. And then they had an intervention arm that offered hospital at home care between 2001 and 2002. And they found that 84 patients accepted who were offered and 57 declined. But I will note that they actually included data from the declined patients as well, so as to not try to kind of dilute the results or create a bias. So, so the 3 sites that they included were actually pretty much all over the country. They had the VA and 2 hospitals in Buffalo, New York, Fallon Health in Worcester, Massachusetts, and the Portland, Oregon VA. So in some of the demographic data, you can see on average, patients were elderly, mean age is around 77. It was majority white, especially in Worcester, Massachusetts, which is quite white, but you can see that it was generally majority white in these populations. And then they looked at things like impairment in ADLs, and actually quite a few did have some ADL impairment, which would be consistent with the majority geriatric population. So they also included Carlson comorbidity scores, mean number of medications the patients were on, which were generally pretty equivalent. So they looked at some of the data on complications of hospitalization between the observation group and the intervention group that got hospital care at home. And there were some results that were quite significant. So they found that incident delirium was much lower in the intervention group that was taken care of at home, especially in the Buffalo, New York site and in the Portland, Oregon site. They also found that there was a lower rate of bowel complications in one of the sites, a lower rate of emergency situations in one of the sites, and then they also noticed a lower rate of critical complications with the hospital care at home group. So I will say with this study, of course, since the dates didn't really overlap, the observational group was earlier than the intervention group, and the intervention group was again somewhat self-selected in the patients that would join hospital care at home, that would definitely affect the results. So, so that gets to, is it possible to run a randomized control trial on hospital care at home? It is, and they did actually do it at Brigham Women's. So this really was the first randomized control trial and not observational study of hospital care at home. So, so this was conducted at Brigham Women's and Faulkner Hospital, which is a community hospital in Boston, between 2017 and 2018. It was run by Dr. David Levine, who, along with Dr. Bruce Leff at Hopkins, is really one of the pioneers in hospital care at home in the US. So the patients were recruited from the ED. They were 18 years of age and older, reside in a 5-mile catchment area of Boston. And the primary diagnoses, just like with the Hopkins group, included CHF and COPD, but also they said any kind of infection, pneumonias, UTIs, cellulitis, diverticulitis, and then rarely some other diagnoses. They did exclude patients who were homeless or didn't really have a safe home situation, who were living in a subacute rehab or LTC, who could not obtain IV access, who required IV narcotics because of a lot of the regulations around narcotic prescription. And then they needed the person to be able to ambulate at least to a bedside commode, either without assistance or with one-person assistance, and the caregiver was with them at all times if they needed the one-person assistance. So in the Brigham study, this was really a true hospital care at home program. So this involved daily visits from an attending general internist. So two of their hospital at home program physicians are primary care, 3 are hospitalists, and all of them worked 7-day shifts, just like we do in the hospital. They also had 2 visits daily from home health RNs. If needed, they would have meals available through the Community Servings of Boston program. They also had home health aides, social workers, and PTOT available. So select specialists could also be available via telemedicine, such as cardiology, infectious disease, nephrology. And then they could provide a pretty significant level of care. They had respiratory therapies, IV medications, via Smith's medical infusion pump, in-home radiology, including X-ray and ultrasound, although of course, for things like CTs and MRIs, they would need to be sent out to a center that could perform those. Point of care blood diagnostics through Abbott Labs. And they're actually in the Brigham program have this very fancy device called the Vital Connect patch. So this is actually a private company based in San Jose, California, that makes this patch that can actually, it actually does telemetry as well as temperature, heart rate, respiratory rate. And so you can monitor telemetry on it as well. And typically it lasts 7 days. So once you put the patch on somebody, you can monitor them continuously for up to 7 days. So in the Brigham study, 248 were screened for eligibility, and they kept them relatively evenly matched. They found 43 were enrolled in hospital care at home and 48 were in the control group, which was in hospital care. So without delving too much into this demographic data, they found that the hospital care at home patients on average were older. The mean age was 80 compared to about 72 in the hospitalized patients. Less of them were Black, more were white and Asian in the hospital at home group. And interestingly, there was actually a relatively even number who lived alone in both groups. And then they found that the hospital and home patients, more of them had Medicare, and also more of them were DNR. So I think it is important to note here that only about 63% of the patients in the hospital home group were full code status versus 90% of patients in the hospital, because definitely that would affect maybe people's comfort level of doing hospital care at home. And then there were more patients who were kind of considered terminally ill in the hospital and home group. So, only about 51% would the physicians be surprised if the patient died within 1 year in the hospital and home group versus about 70% for the hospitalized group. In terms of the type of diagnoses that they took, they were actually more cellulitis patients in the hospital at home group and less diverticulitis, or actually no diverticulitis patients in the hospital at home group, but otherwise they were relatively evenly matched by diagnoses for pneumonia, UTIs, COPD, heart failure. And then some of the other rare diagnoses they took to include diabetes complications, providing end-of-life care, and then anticoagulation bridging. So these were some of the results from the Brigham study. So some interesting ones to note was that there was probably makes sense, but there was significantly less imaging done in the hospital at home group. Only 6 patients in the hospital at home group had imaging during their admission versus 21 in the control group. And then also significantly less labs were drawn. So on average, only 3 labs were drawn in the home group versus 15 during the admission in the control group. And then in terms of 30-day readmission, they actually found some really great outcomes in the hospital at home group. They found that only 3 were readmitted in the hospital at home group versus 11 in the control group. And then similar for ED presentation, although not as stark, that about 3 had a 30-day ED presentation compared to 6 in the control group. In terms of the just quality of care and functional status, so it was actually interesting because a lot of the hospital and home observational data had found that functional status was relatively improved in the hospital at home group. This study, which was the first randomized controlled trial, actually found they were relatively equivalent in terms of functional status and whether their ADLs and IADLs were worse at discharge or 30 days after discharge. Patient experience was also relatively equivalent between the two, and then safety events were relatively equivalent. But we did find that the median percentage of the day that the patients were laying down or sedentary was much lower in the hospital at home group. So only about 12% of the time were they sedentary and 18% lying down versus almost 55% of the day they were lying down in the hospitalized group. And then in terms of cost reduction, they did find that the acute care episode, the cost, there was a 41% relative reduction and 38%, when adjusted for sex, age, race, ethnicity, education, and discharge diagnoses. With physician labor included, those numbers are not quite as large, but there is still a cost benefit, about a 19% relative reduction, even when you include the cost of the daily physician visits. And again, looking back at this data, you can see that it's relatively equivalent in terms of quality of care, but at a lower cost, so which is compelling data to pursue hospital at home. And then in this Brigham study, they actually did a separate article just kind of trying to ask patients what their experience was and trying to get some qualitative data on it. And the hospitalized patients mentioned, it's busy. They wake you up every hour, on the hour at night. It's not conducive to relaxation. I got everyone coming in and buzzing and everything. And the ED is the worst part of my stay. Laying around there for 10 hours is not easy. And which obviously would be the case when we have very high ED holds. For the hospital at home patients, they found it was convenient. They didn't have to travel back and forth to the hospital. When they were released, maybe they had a bunch of appointments coming up and those kind of things. So they didn't enjoy that part of it. And this is also true for caregivers, because oftentimes in a hospitalized patient, caregivers may be coming every day to see them, which they wouldn't have to do if they're at home. So of course, like anything, there are barriers to hospital care at home. So the barriers can really be in several groups. So one is regulatory and policy barriers. There's a lot of policies and a lot of regulation involved in this, just as it is in, for example, in the subacute world. So we need to make sure infusion pharmacies are able to dispense outpatient meds, scope of paramedic control. So in New York, for example, only EM physicians can direct paramedics. And so they needed to kind of have a special program to get around that at Mount Sinai's program, which is a pretty large hospital care at home program in New York City. And then you have to really train non-infusion home health nurses to perform infusions because the scope of care in acute hospital care at home is different than the scope of care for an average home health nurse. Billing and payment can be an issue, so multiple individual payments for the physician, for the nurse, and IV medication. So even with if they only have a 15 or 20% copay, the patient's going to be getting billed for each of these rather than a super bill, like when they're hospitalized. Identifying and recruiting patients, you'd have to gain buy-in from busy and sometimes skeptical referral sources such as physicians, and then finding eligible diagnoses and making sure there's adequate services. EHR implementation, which is something we've dealt with at our own program, where you really need your own Epic build for hospital care at home. And that obviously can be very time consuming and nothing really moves slow when you're trying to build a new Epic system. So that's something you really need to plan pretty far in advance if you're trying to institute one of these programs. And then development of partnerships. So, some of the programs like Hopkins, the Harvard programs, the Mount Sinai programs are in relatively large cities. So you have a pretty large patient base right within the city. That is not true at Michigan, where, we are a large hospital, a relatively small county, and we have a very large very vast patient base that goes into a very large part of the state and in more rural areas. So we generally want to start with a smaller service area like we would here in Washtenaw County, and then expand beyond that once you already have those partnerships developed. And then you want good coordination and communication between providers, the physicians, nurses, paramedics, pharmacy, and therapists. What was the effect of COVID-19? You saw these little programs starting up at Harvard, at Hopkins, at Mount Sinai, but it was not really on the radar until 2020 when we first had a public health emergency declared by the US government on January 30th with the advent of COVID. And this has allowed significant flexibilities, including the patients who are on Medicaid cannot be kicked off Medicaid rolls, even if they no longer qualify per state rules during this public health emergency. We've been getting free COVID testing and treatment. It's been affecting telehealth. So billing for telehealth is much easier during the public health emergency. And I think some hospitals may have noted this, but we no longer require the 3-day hospital stay for transfers to subacute rehab. So that has also been because of the public health emergency. And also it has had a significant impact on hospital care at home. We found that the Hospital Without Walls initiative was created by CMS on November 25th of 2020 after 2 major surges when they were really finding that a lot of hospitals were just completely full and overwhelmed. So this waived the requirement for nursing staff to be on the premises 24 hours a day, 7 days a week, which really opened the door for acute hospital care at home. And just like what they did in Victoria, Australia, they allowed this to be billed and paid the same as an acute inpatient hospital stay for Medicare fee-for-service patients and some Medicaid patients. So it exploded with this Hospital Without Walls initiative. So now we went from maybe less than 10 hospitals doing it before the pandemic to now 186 hospitals and 82 health systems in 33 states have enrolled as of October 27th, 2021. And the geographic distribution of the waiver uptake. So you can see a lot of the Midwest has been involved, the Mid-Atlantic, the West Coast. We don't have as much in the Mountain West, with the notable exception of Utah, which has a pretty strong program through their cancer center. And probably because it may be just geographically more restricted because those are mostly rural states. So what is involved in this hospital care at home waiver? So like we had talked about before, you need access to the following services and need contracts with all of these: pharmacy, infusion, respiratory care, diagnostics, monitoring with at least 2 sets of patient vitals daily, transportation, food services if needed, durable medical equipment, PT, OT, and speech, and social work and care coordination. You need at least 1 daily physician visit or nurse practitioner PA visit. So the initial visit always has to be done by a physician, the initial in-person history and physical. The subsequent visits can be remote and can be done by either a physician or a mid-level practitioner. You need at least 2 in-person daily visits by either a nurse, or this is mobile integrated health or community paramedics. So typically you can either do 2 nurse visits or 1 nurse visit and 1 community paramedic visit. And then immediate on-demand remote audio connections. So the team needs to be reached 24/7 and available 24/7 for any emergencies. And in this case, for the waiver, only patients who are already in an ED or inpatient hospital are eligible. So this program would not allow a patient to be kind of averted from the hospital and to the hospital care at home program if, for example, if a primary care doctor is worried about them. You need to agree to voluntarily provide volume escalation rate and unanticipated mortality numbers to CMS for analysis, and have the equivalent of morbidity and mortality team to review these metrics. So in terms of the PHE and the effects that it's been having on our care as hospitalists, so it's been renewed 8 times for 3 months each over the last 2.5 years. I don't know if you had noticed, but just this past week, it was renewed on April 13th. It was about to expire actually on April 15th for 90 days until mid-July, but it is unclear if it'll be renewed after the summer. And so the downstream effects, if the public health emergency ends, so COVID-19 testing post-acute treatment will no longer be free. So all those people who could not really be kicked off their Medicaid rolls will potentially lose their Medicaid health insurance, which would affect the ability to pay for a lot of services, hospitalization and hospital at home services. And then the hospitalized Medicare patients would again need to have 3-night stays to qualify for SAR. And hospital care at home would unfortunately no longer be paid at inpatient rates by Medicare. So I can tell you that our program here at Michigan Medicine, we are running a kind of a program with Blue Cross Blue Shield, which would not be affected by the public health emergency, but we recently started taking Medicare fee-for-service patients. So we're keeping a pretty close eye on this as far as our traditional Medicare patients. For anybody interested in health policy or advocacy, there is bipartisan legislation pending in Congress to extend the hospital at home program for 2 years after the public health emergency ends. And most of you are aware that bipartisan anything is not common in Congress. So it does seem like this is actually an issue that is motivating both sides of the aisle, which was definitely encouraging. So there's one bill in the Senate right now with Tom Carper, who's a Democrat, and Tim Scott, who's a Republican, and one in the House with Earl Blumenauer and Brad Wenstrup, also both sides of the aisle. So, but if you remember your Schoolhouse Rock, I'm just a bill. It does take a really long time for things to sit in committee. So we're keeping an eye on it, but it may be kind of a slow process to really make sure this happens before the public health emergency will potentially expire this summer. And so just wanted to turn a little to the Michigan Medicine experience. So this is Dr. Jenk, who's our fierce leader with one of our first hospital care at home patients and his dog. So we now have several care at home pathways. So a lot of these pathways have been up and running actually for the past year. So we do have the ED to hospital care at home program, which is through Blue Cross. And we also have the CMS waiver I just talked about, an outpatient ED to observation at home program through Blue Cross, and something called the CMS Safe Harbor program. And then we have observation at home, inpatient observation to inpatient to home through MSSU, and we've had a couple of patients come through this pathway. And then the completion at home pathways, which a lot of you may be familiar with because as I'll get into the next slide, we've had a very successful COVID completion at home pathway, and we've also had some patients come through our CHF and ileostomy pathways. So thanks for the future is we are looking to proactively intervene before patients need an ED or hospital stay. And so there's multiple ways that we're looking at paying for this. And then actually in June, we're doing a transfer to home pathway, which hopefully will make this process easier because everything would be just basically through an Epic order set, which would be very similar to that that we use for our hospitalized patients. So COVID completion at home, these numbers are as of April 15th. Since the program started in November of 2020 during our second surge, we've had 440 patients come through the program, and it's been very successful. We've saved on average about 4 bed days per patient. So you can imagine over 440 patients, that's well over probably 1,500 bed days saved. So, so it's been really successful and been a really great way to kind of get patients out of the hospital safely and open up those beds for patients who need them. So we've also had some success stories outside of COVID, which many people outside our group may not know about. So, so one of our first patients was a perforated diverticulitis who didn't need surgery. So he came into hospital care at home on IV antibiotics, did really well. And then CHF, hospital care at home on daily IV diuretics and labs. An aspiration pneumonia patient who got antibiotics and oxygen at home. A metastatic melanoma patient who came in with sepsis, really did not want to be in the hospital and wanted to bridge to hospice, but the hospice wasn't available at that moment. So essentially we acted as a bridge for this patient to hospice. So, so she was able to get a much better experience being at home with her family. A siladenitis patient with IV antibiotics and steroids, and a couple of cellulitis patients who did really well. So I wanted to put in a plug for the patient monitoring at home program, which is run by my colleague, Dr. Thoma. All hospital care at home patients do get a patient monitoring at home kit, but you can also order it without hospital care at home. So this allows for monitoring of high-risk patients for 21 to 45 days after discharge from the hospital. Common conditions include CHF, cirrhosis, COVID, COPD, hypertension, and sepsis. We've found 17% reduction in the average number of emergency room visits 6 months before and after enrollment in the program, and 64% reduction in the average number of hospital admissions 6 months after enrollment. So 78% reduction in COVID patients, 54% for CHF patients, and 33% for uncontrolled hypertension, because we really want to use this program to try to catch, weight changes for CHF patients, high blood pressure changes for these patients, to make sure that, we can adjust things at home before they end up back in the ED. And if you're interested in enrolling one of your hospitalized patients for this program, place an EPIC order about 1 to 2 days before you're expecting them to discharge. So we want more patients. A big part of my presentation was to really get out there and actually get more patients. So you can reach us 24/7 at the Michigan Medicine pager 61576. Our leader is Dr. Grace Jenk, who's the Associate Chief Clinical Officer for Post-Acute Care. I'm currently medical director for the hospital care at home program, so you can definitely reach me as well. And then this is our whole team. So it includes Dr. Gus Thoma, who's medical director for patient monitoring at home, Dr. Alex Norica from geriatrics, Dr. Capizano and Dr. Mussolf, who are both from family medicine, and Dr. Kurt and Sue Camper, who are internal medicine primary care. And then we have an alumnus, Dr. Emily Maris, who's now a medical director at Arbor Hospice. And soon to join, we actually have a couple of hospitalists joining our group, Dr. Dan Giesler and Dr. John Hunter. So we have a really diverse team here, and I think that definitely lends a lot of value to the care we provide for our hospitalized patients or hospital at home patients. And we have multiple RNs, nurse practitioners, admin support staff who are really critical to the work we do. And that is it. So thank you, everyone, and go blue. This is my family up in Banff in Canada in 2019, and this is my senior dog nephew, Lucky, running on the Oregon coast. But, thanks, everyone.
We do have some time for Q&A, so if anyone has a comment or a question, go ahead and type that and enter it into the Q&A box. We'll give a few moments for that, so in case anything comes through.
All right, getting a few things, a few questions coming through. So thanks to Dr. Kirk Hamper, just to say a helpful, interesting presentation, and then Rachel Perlman. There is an anonymous question. You mentioned co-pays for patients. What are their out-of-pocket costs, and are you looking at that? So yes, we are. And so this has been kind of an issue. Like, for example, with CHF patients, they may have to pay for every IV Lasix that they get. What we're really trying to do is trying to compare what their super bill would be, if they were hospitalized for the same condition. And then, we are looking at that. So Lucy Hochran, who's kind of our financial guru for the program, has been looking into a lot of these billing matters. So definitely something we're working through, but we want to create a lot of transparency, when we first offer the program. And I have to say, this program is completely voluntary. We're never going to, force anybody to be in the program if they don't want to. So, but if somebody's really indicated that they are interested in going home, we want to offer full transparency in terms of how much things cost. So, and then there was another question about, did you encounter any unexpected complications at home and codes at home. So fortunately, we have not had any codes at home, but there have been complications. So sometimes, we really try to do what we can. For example, we had an ileostomy patient recently who was a completion of home program, and he was quite sick to begin with, and really pretty high need, really needing daily visits and things. But we were able to get, we noticed that there were some increased liver enzyme numbers, and we were trying to figure out why. So we were able to get an ultrasound at home, just to look to see if there anything was going on with the liver. We ended up finding it was most likely related to the TPN he was getting, but we're able to kind of deploy a lot of technologies into the home. If things are really serious to a point that we feel like they need a CAT scan or an MRI or something, and that really cannot be urgently set up, then we do end up sending them back to the ED. But fortunately, that's been relatively rare till now. And then how do you handle full codes at home? Again, good question. So some of the patients have been full code. The biggest thing is if there really is an urgent situation, we would call community paramedics to try to get in there as soon as possible. But if it really is something that, somebody's become unresponsive, then they just need to call 911. And usually that means that you would have EMS coming in and probably taking them to the hospital at that time. But again, not something we run into frequently at this point. I think most of the patients we've been taking either are more DNR patients or patients who are not really seriously ill. For example, the diverticulitis and cellulitis patients were more observation level type patients. Any other questions?
We can give another minute and see if anything else comes in.
Are you collecting patient feedback? Yes, so we are. I didn't have a chance to, post some of the, feedback we've gotten, but yeah, so far a lot of the feedback has been positive, and definitely we can kind of collate some of the feedback when we're looking, maybe into a document to try to present to patients who may be interested in the program. And if the PHE is not renewed, how will that affect your services? Great question. Basically, we're looking at, that will really only affect Medicare fee-for-service if the PHE is not renewed, and if those bills currently passing their way through Congress aren't passed by July. So then our ability to take Medicare fee-for-service patients may change, but the Safe Harbor program, and there's some other like innovation initiatives through CMS, the Center for Medicare and Medicaid Services, that we may still be able to enroll Medicare, but I think a lot of our patients, like we were doing in our initial pilot phase, are going to be Blue Cross Blue Shield commercial, which will not be affected by the PHE. And with other payers, and we're also trying to enroll other payers right now, including other commercial payers. So. What about the 15 million Medicaid patients who may lose coverage? So that, that is not necessarily exclusive to hospital care at home. It is definitely a concern of many in the medical community right now, because of course it'll affect all kinds of care, primary care, hospital level care. So, but yeah, Medicare fee-for-service and Medicaid are essentially under one umbrella right now with the CMS waiver for us. So, so our focus would really be on those with commercial insurance. And what is the biggest barrier to hospital at home to date? Getting patients to agree or physicians to make referrals? So it's actually been the latter. I do think it's more that we found that it's harder for getting physicians to make referrals. We've actually noticed a lot of physicians do feel people may not qualify medically, but when we kind of look back at these patients, we feel like that they may be a candidate. I had presented earlier that there's been encouraging literature in ALS and neuromuscular disease populations. So even people on chronic home vents, if they're coming in with something relatively simple, like a cellulitis or UTI or something like that, we can take care of them at home. If they have a chronic vent at home, and they have somebody who's helping manage their chronic then, you know, that isn't necessarily something that will prevent admission to our program. So, but people may not recognize that and recognize that that's a population because they are seriously ill, certainly, that we can take care of. So, so yeah, what I think once we offer it to patients, there has definitely been a high uptake and reception rate for the program. You mentioned patient monitoring at home. Is that expensive or covered by Medicare? It is covered by Medicare. So Dr. Gus Toma would definitely have the details on that program, but it is not expensive. We're not using the fancy Vital Connect patch that Brigham and Women's was using. So I think we do have basically different types of kits. Some include weight scales for CHF patients. Some are what we call mini kits that really are just kind of pulse ox, you know, blood pressure cuff. And so those are relatively inexpensive and they are covered by insurance. Any other questions?
All right, I don't see anything else in the Q&A box. So I want to thank you, Dr. Rangarajan, for a wonderful Grand Rounds presentation today. And thank you everyone for attending, and have a great weekend.
Thanks. Have a good weekend, everyone. Enjoy the beautiful weather, the 80 degrees. Thanks.